The future is now when it comes to obesity care, and we're going to be telling the story of ones today. One new treatment that could change the future of obesity medication forever. One new policy change that could open up the floodgates for folks on Medicare to get coverage. One amino acid that could reclassify Retatrutide. There's a bunch of information on Retatrutide this week that could totally impact compounding. And one new indication that could also open up the floodgates for millions of people to get coverage for GLP-1 through their insurance. We're going to cover all of that this week. But before we do, let's roll that bumper.
Welcome to the On the Pen podcast with your host, Dave Knapp.
Welcome to this Tuesday, October 7th edition. I can't believe it's October 7th edition of On the Pen, the weekly dose podcast. I'm your host, Dave Knapp, man on the Manjaro. That's why I'm here. You are on the pen. That's why you're here. Wegovy, Saxenda, Victoza, Trulicity, Manjaro, Zepbound, Compound, That Pen. And we've got a bunch of stuff. One of the most exciting podcasts that we've done in a long, long time to get into some stuff that only we're covering here at On the Pen. We're going to get into our first story this week. It's a gene therapy for obesity. The Fractyl data that dropped just today. Now, if you remember last week, you may be having some deja vu. We had Harith Rajagopalan. He's a doctor who is also the CEO of a company called Fractyl Health. And last week on the podcast, we learned about how their Rejuva program is helping patients who get to goal weight with a GLP-1 medication maintain their results with a simple endoscopic outpatient procedure that is really absolutely a game changer. It's a mucosal resurfacing of the duodenum that allows your body to sense the nutrients you're eating and just respond more appropriately with hormone secretion, right? These are analog hormones. This one, GLP, GIP. Now that sort of tees up what we're going to talk about today with information that we got on their program called RJVA-002. Now, Harith teased this last week. This is a gene therapy that has the ability to basically program your pancreas to make more GLP-1 and GIP. So it's like basically just teaching your body to make more of this naturally. Now, the reason I like this is because what we've seen with the RJVA-001 program, which is just the same thing, but minus the GIP, it's just GLP-1. That's actually in human trials right now. What we've seen is that with this one and done GLP-1 treatment, patients are responding better to that single gene therapy than they are to the injectable medications that are out there right now. And we're going to get more data on that in 2026. But RJVA-002 works on both incretin hormones, GLP-1 and GIP. And in this preclinical data that we got just this week, it showed patients lost, I shouldn't say patients, mice lost up to 30% of their body weight and didn't even plateau. So they were able to lose 30% of their body weight by this gene therapy that just simply allows your body to make more GLP-1 and GIP when you eat. Now, endogenous, the kind that your body makes, GLP-1 and GIP, just lasts a couple minutes in your body. So your body makes more of it on demand. You get a more strong sensation of fullness and a more efficient release of insulin and slowing of the gastric emptying, all of that. But the incretin hormones that your body makes go away after a few minutes. With these, they last for a week in your body, and they're allowed to penetrate deeper than your endogenous hormones are. And there's just, frankly, there's some unknowns about that, right? Although GLP-1 medications have been around for 20 years, GIP medications are pretty new. And this is 5-to-1 GIP to GLP-1. So it's much more a GIP medication than it is GLP-1. Now, in terms of the effectiveness for weight loss, the quieting of food noise, all of those things, GLP-1 GIP has been shown to be the way. I mean, it is the future. There's data from a company called Calvia this week on a GLP-1 GIP that they have. Of course, there's Viking Therapeutics VK2735. That is an amazing candidate that looks like it will be a game changer. Even Eli Lilly has a second generation GLP GIP in the pipeline that just shows me that this is probably the way where Novo Nordisk has really hung its hat on this idea of amylin agonism coupled with GLP-1. Lilly has led the way with this GLP-1 GIP, and with the RJVA-002 program, it's a gene therapy program that programs your pancreas to release both GLP-1 and GIP, our favorite of the two incretin hormones, using beta cell specific nutrient responsive promoters. So it's like telling your body, hey, just make this medication yourself. And I think that's what's really exciting about this. Now, look, I know that when we talk about these gene therapies, there's a lot of people that cringe and go, I'm not doing that. And, I'm not going to be the first one to sign up for it either. But that's why there are preclinical models in animals before it ever goes to human testing. And that's why we do clinical trials. But let me tell you, this thing passes clinical trials. This is a potential absolutely breakthrough therapy that could change the game, not only for the injectable medications that we rely on right now, but also for the future of metabolic surgery. Just think about the potential. Well, is there risk with the gene therapy that lasts forever? Of course. Of course, there's risk. Of course, there's things to consider. And of course, we should scrutinize the data. Of course, we should ask questions. But when it comes to metabolic surgery, and the rerouting of your anatomy, is there not risk with that as well? Of course, there's risk. It's always about the trade-off. What is the risk of living with obesity long-term? We know what those risks are. 13 different types of cancers, cardiovascular disease, just a kidney disease, a cascade of comorbidities that happen, right? So that's what the clinical trials are for. And this early clinical data on this therapy is huge. RJVA-002. You're hearing about it first here at On the Pen. I'm super excited about this one, and I hope that the science holds up on this as it moves through the clinical trials. And we'll continue to bring Dr. Rajagopalan back to On the Pen as this data sort of evolves over the next couple of years to hear about this, because I personally get really excited about being able to treat my chronic disease of both obesity and type 2 diabetes with a one-and-done treatment that is less invasive. Again, it's a minimally invasive endoscopic outpatient procedure. Very, very fascinating. And we'll continue to follow the science as it evolves here. Now, the second story that we're going to cover this week is another really exciting story because we heard from Dr. Oz yesterday. He was speaking at the Aspen Institute. For those of you who may not know what Dr. Oz does, he's now not just like an Oprah doctor. He's actually heading up CMS, right? Sometimes I recoil when I make statements like that, and I go, is this the world we live in? But yes, it is the world we live in. Dr. Mehmet Oz is the administrator of CMS, which oversees Medicare. And he was asked about GLP-1s being covered for obesity. Now, you may remember at the tail end of the Biden administration, there was a rule floating around, a potential rule change floating around that would have actually added GLP-1s to Medicare for obesity. But the Trump administration, much to our chagrin, shelved it. But at the time, I was trying to figure out why would they shelve that? I mean, the data is piling up that these medications have the ability to really, what I believe, is save our healthcare system here in the United States. So if we're reading that data all sort of the same way and going, how can we deny that this, despite what the CBO score says, that this is ultimately going to make people healthier? I think everybody's there and everybody pretty much understands that now. So why would the Trump administration shelve this? Well, at the time, my theory and what I was kind of surmising was happening behind the scenes is that the Biden administration, sorry, I've got Ella with me and she's dreaming. Can you all hear her? Ella, hey. Yeah, it's okay. We're doing the podcast together today, aren't we? So ultimately, the Trump administration is likely looking at adding these to Medicare, but also looking at it because what they've shown us is that they are going to use every lever of government to try to bring down the price of these medications. And now you can argue that it's all smoke and mirrors, and to some extent, some of it is. I mean, some of these medications that, for example, Pfizer has agreed to lower the drug costs on are drugs that are already widely covered by insurance. And so bringing the cost of those medications cash pay down doesn't do a whole lot for people, because if you're covered and you're already getting those medications covered and they're widely on formularies, how does that help people? But so this will all come out in the wash, and we'll we'll have to do a postmortem on all this. But what I think the Trump administration identified here was essentially, listen, we can add these drugs to the formulary, these GLP-1 drugs for obesity, but that would be a huge boon for both Lilly and Novo. So we should be able to arbitrate the cost down on these medications if they want access to Medicare formularies and Medicaid formularies. And so what I think is going on behind the scenes is there's talks about most favored nation. There's talks about bringing the cost of these down if they want access to these. And so these are all kind of happening at once. And so I don't think it was an accident that the Trump administration shelved the rule that the Biden administration put forth towards the end of their administration. I think it was they wanted to use it as a lever to bring down the cost of these medications. So I believe that's ultimately what's going to happen. But essentially, I think we're going to get a huge announcement. I think we're going to get a huge announcement from Lilly and the Trump administration on the adding of these GLP-1s to Medicare. I think we're also going to see the prices lowered, but I don't think that that's going to happen without a trade-off. So what do you think that trade-off might be? And this is something that we've been speculating a lot on the pen. What is that trade-off? Well, we know that both Lilly and Novo have spent an exorbitant amount of money, put forth some massive campaigns to cast a shadow of doubt over the safety and legitimacy of compounded versions of their medications. We know that. So if they've got Lilly and Novo at the table on potentially lowering the cost of these medications, don't you think that Lilly and Novo's ask of the Trump administration is more enforcement over the compounded versions? I think that's the trade-off. I think that's what's being hashed out right now. I think that there are likely demands on the part of the pharmaceutical companies, that there are concessions on the Trump administration's part that they will enforce, use the levers of government to enforce against compounders. Now, how could they do that? If the Food, Drug, and Cosmetic Act allows for personalized medication, how could they enforce anything? Well, I think there's an argument to be made. Again, I'm not saying that I agree with it or want compounds to go away, but I think there's an argument to be made here that with the compounded medications, personalized medicine made on scale, especially by 503B pharmacies, is not personalized. It's just different medication done at scale. So I think that what they're going to do is ask for a different interpretation than they've had historically on that, and they're going to ask for enforcement. I could be wrong on this, but doesn't it stand to reason that that would be a bargaining chip that would be being used at the table by Big Pharma, knowing everything that we know? So we'll have to see how this all plays out. We may get cheaper GLP-1 branded medications, but the trade-off could be a crackdown on compounding. It just could be. It could be. And so we're, again, going to follow this extremely closely. At the end of the day, we want more access to more medication, more treatment for people living with the disease of obesity. That's what our hope and prayer is for each and every one of you within the sound of my voice, is that more people get access to these treatments. So at the end of the day, we're for anything that improves that. But I'm not certain that these drug companies, even with lowering the price, will be able to meet the demand if all of a sudden compounding is turned off. Now, will it be turned off overnight? I don't think so. If you're on a compounded med, this isn't like a reason to go out and panic buy and stock up. But it is a reason to pay attention, because there's going to be a lot of announcements that are going to be, it's going to be a lot of information to sift through. And we're going to have to try to separate the wheat from the chaff and find out what this actually means for patients. Of course, you can trust On the Pen to bring you that information from the patient perspective. Everything we do here is designed to help you have more competent and confident conversations with your doctor so that you get better health outcomes. That's the goal here of everything that we do. So if you're new here, you're just stumbling upon this podcast, my ask of you is that if you're watching on YouTube, you'd hit the subscribe button and hit the bell to get notified every time we drop news here at On the Pen. And that if you're listening on the podcast, that you would take 2 seconds and scroll down and give us just 5 stars on the rating area. That helps other people get access to this content as we put it out. I hope that you will just take a quick moment to do that. Thank you to those who have done that already. We have 4.9 stars out of 5 with now over 300 reviews on the podcast. So thank you to everyone within the sound of my voice who has taken the time to just do their little form of advocacy and help and get the word out about what we're doing at On the Pen. So bottom line on this whole story, pharma's pushing hard. And enforcement on compounds may be the price that we pay for cheaper branded medications. We'll see. We'll see on all that. I hope that I'm wrong. I hope that accessibility to all forms of GLP-1 remains the same, but we'll have to see. We'll have to see. Want to take a moment to bring you a word from all of the wonderful people here that sponsor the work at On the Pen, the work that we do here. We couldn't do it without our sponsors, and so we're going to hear a little bit from them this morning. I want to thank our sponsor who brings this podcast to us each and every week, Ro. This past week, we got some news from Ro in terms of a massive sponsorship that they started with none other than Serena Williams. You have to have been living under a rock if you missed this news about Serena Williams and her use of GLP-1 medications, basically coming out and saying, hey, she couldn't do it alone. She was fighting some broken biology, and that the use of GLP-1 medications was what she seemed to have been missing. So you can check out our sponsors at Ro because we saw what Serena saw, and that the best platform to get it from is Ro. You can visit ro.co/OTP and learn more about their Ro Body program, where patients lose 15 to 20% of their body weight in a year, coupled with lifestyle modifications and medication when appropriately prescribed. Love our partners at Ro. Check them out at ro.co/OTP. Just a great program over there. I really appreciate Ro helping us to do this podcast each and every week. But I am curious, for those of you who haven't checked in a while on the branded medications, if you've heard about our sponsors, Claimable is actually a company that provides a service that allows you to fight back against your insurance company denials. Now, insurance companies rely on 90% of the patients that get denials never fighting them. And they don't fight them because the process, quite frankly, is cumbersome and convoluted. So what Claimable does is they provide a platform that allows you to compile all of your case, and they help you build that medical case, that legal case, and then they help to create that case and send it off to all the interested parties. Claimable does all of that. You can check them out at getclaimable.com/OTP. Use code OTP10. It'll save you 10% off. You got a 50% shot at getting it covered. I'd say that's worth the $40 to see if you are one of the 50% that ultimately does get your medication covered. I do want to shout out our sponsor, Shape'a, who has continued to help me to stay on my journey. And the Shape'a actually changes the way we track our health. Instead of focusing in on that daily number, it helps us focus in on a pattern. And we want to stay in the pattern of weight loss. We don't want to get sidetracked or derailed by these day-to-day fluctuations. So no numbers, just colors to track your health trends, looking at things like your water weight and your body composition, and using that algorithmically to help you stay in a color-coded pattern that is simple and has a way of helping you stay engaged when you're with your health. Listen, when I'm engaged with the scale, it means I'm engaged with my health. And so Shape'a helps me to stay engaged with the scale. Check them out at myshape'a.com/OTP. Use code OTP30. It's going to save you 30% on the Shape'a scale. This is a wonderful tool for patients living with obesity. myshape'a.com/OTP. Use code OTP30 to save 30%. Love what they're doing at Shape'a. Now, this one is a story that we have been following now for over a year at On the Pen, and it has to do with how the FDA is classifying Retatrutide or Retatrutide as a peptide drug and not a biologic drug. Let's talk about a ruling that came out last Friday in the Eli Lilly versus FDA case over this topic of Retatrutide, because this one actually matters way more than people realize. And it could even be playing into the previous story in terms of how these negotiations are panning out with most favored nations and adding GLP-1s to Medicare, et cetera, because the FDA could just decide to stop fighting this also, right? So here's what happened this past week. A federal judge just said that the FDA acted arbitrarily and capriciously when it rejected Lilly's bid to classify Retatrutide as a biologic. So the court didn't hand Lilly a complete and total victory here, but it didn't side fully with the FDA either. Instead, it basically kicked the decision back to the agency, basically saying, you didn't explain yourself well enough, do it again, and this time justify it. So that might sound technical, but it's actually a huge deal because it cracks the door open for Lilly to make the same argument again, but stronger. And if the FDA caves or revises its definition of how you classify a biologic, it could change the rules for all the GLP-1s that are out there. So here's why. This argument and you got to stay with me on this because this one gets a little bit in the weeds. But the argument is around the length of an amino acid chain. So the FDA basically says a molecule has to have more than 40 alpha amino acids to be considered a protein, which would then qualify it as a biologic. So retatrutide has 39 alpha amino acids, but it also has 2 non-alpha residues. So 41 if you count everything. Tirzepatide, Mounjaro and Zepbound, have 39 all alpha, and semaglutide has 31 also all alpha. So right now, only the alpha ones count, which is why both semaglutide and tirzepatide are classified as drugs and not biologics. That's what allows them to be compounded, right? When there's a shortage or there's these, idea of personalized medicine, it allows it to be compounded. If it's a biologic, it cannot be compounded. But Lilly's argument here is that the FDA should count all amino acids and all the amino acid residues, even the non-alpha ones, because they contribute to how the molecule functions in the body. So if the FDA were to accept that argument, retatrutide crosses the 40 amino acid line and becomes a biologic. Now, this is hugely, hugely impactful if this were to be successful. So if retatrutide is recognized as a biologic, it legally cannot be compounded ever. Biologics fall under the Public Health Service Act, not the Food, Drug, and Cosmetic Act, which oversees compounding, which is what 503As and 503Bs pharmacies operate under. So that means if the FDA adopts Lilly's broader definition, it sets a huge precedent, not just for retatrutide, but potentially for peptides, tirzepatide, future GLP-1s and GIP drugs too. And if that happens, this has 3 massive implications for patients. This is where you need to have your ears perk up. The implications here are compounding tirzepatide could be actually looked at again. And the compounding of all peptides could be looked at again because it sets a whole new precedent for how you interpret the classification of these drugs. Future and next generation incretins could also be off limits when they launch because, again, this changes the definition, and access to these drugs for patients who rely on the lower cost versions would be eliminated, could be eliminated. So this has huge implications, not only for retatrutide, but how the FDA interprets all of this. And I think that's huge. This is a huge story to follow. So the judge did not declare that retatrutide is a biologic, but it's calling the FDA's reasoning arbitrary and capricious. So he forced the agency back to the drawing board on this. And that means that the story isn't over. It's entering a new round of sort of this legal and regulatory back and forth. So you can bet that Lilly's going to push hard here. They've got a lot to gain because biological status for retatrutide would mean 12 years of market exclusivity instead of 5. It would lock out compounders, and it would give leverage and pricing control heading into retatrutide's eventual approval. It's also going to, cast a shadow of doubt over the compounding of all of these medications because you're jimmying with how the definition is done here. It's setting a precedent, right? And that precedent setting could potentially impact the future compounding of all peptides. So while compounded tirzepatide and semaglutide are safe for now, this ruling would plant a seed for the future where no GLP-1 could be compounded depending on how hard the pharmaceutical industry wants to push. And they're going to push hard. So the future where you could imagine that happening got closer with this ruling, not farther, because the door was left cracked open by this judge for Lilly to continue to push through. So is anything going to happen overnight with this? No. But this is something to watch, and it's bigger than retatrutide. This is a potential precedent setter, and it could have implications on all compounded GLP-1s. And I think it's something that we got to watch. So when you zoom out, this isn't just about retatrutide and a single court case between Lilly and the FDA. It's about who gets to control the most effective class of obesity medications ever created. And if the definition of biologic gets changed, so does the entire playing field for how this stuff is compounded. And once that happens, it could affect everything. Is it a super high probability that it does? I don't think so. But this is all the wild, wild west. This is all uncharted territory. And this ruling could quietly become, one of the most important turning points in the GLP-1 story so far. So we flagged this about a year ago. This is starting to materialize in the courts. We had this ruling, the summary judgment, and the reality of it is that the door was left cracked open for pharma to go through. So this is a huge story, and I think this is one that we need to majorly be paying attention to. There are other creators following this thread now too, and I think importantly so, because this could have massive implications for accessibility into the future. And on the topic of accessibility, we've got one last story for you that is on the more positive side, and I'm excited to get into this one with you. So this week in the news, as it relates to accessibility of GLP-1 medications, specifically branded medications, we've got like a real exciting thing to talk about. Essentially, the MASH indication, we used to call it NASH or fatty liver disease, was actually added for Wegovy, which could potentially expand access to Wegovy to millions of patients. And I thought, who better to talk about this than the CEO of a company we've been working with for some time now called Claimable. Waris Bakari, Dr. Waris Bakari is the founder of Claimable, and they're working to help many of you. I hear from many of you daily that you're able to get back on your branded medication after an insurance denial because of the tool that Claimable offers. But we're always trying to find ways that we can expand access to patients. And I wanted to bring Waris in to discuss how this impacts patients. Waris, welcome to On the Pin.
Hey, thanks for having me.
Yeah, thanks for being here. Yeah, good to see you as always. So in your eyes, Waris, what are the biggest barriers today to making MASH this indication to patients who could leverage it to get access to Wegovy?
Can we back up a little and maybe just talk a little bit about MASH? So there's been some rebranding of MASH. It used to be called NASH and part of NAFLD, non-alcoholic fatty liver disease, and that's metabolic dysfunction associated steatohepatitis. So it's like fatty liver caused by diabetes, effectively. So I have a personal connection to this, which is kind of sad in a way. My dad actually died from MASH. Wow. And so I got to see him go through the stages of cirrhosis and liver failure from it, which was incredibly painful. And if I wind the clock all the way back to like 2002, I was starting medical school and was reading in his textbook about steatohepatitis. And I'm like, yeah, whatever. This isn't going to affect a lot of people. And then, zoom forward to 2015, I met this guy at UCSF called Ethan Weiss, who is a brilliant metabolic doctor. And people should follow him on Twitter because he actually does break down a lot of the science. He was convinced that this was going to become like an exploding part of healthcare cost in the US because of the trends he was seeing in practice. And so that kind of switched me onto it. And then my dad got diagnosed with it. And then I watched his health decline to the point where he was having, massive upper GI bleeds from esophageal varices. And in the end, it killed him. So I got to see it, but it's preventable, right? Like to a large degree, like I wouldn't wish that upon anyone. It's completely preventable and manageable. And even if you have evidence of steatohepatitis, like, can you back it off from becoming like complete liver dysfunction followed by liver failure? And the mechanism, in case people are confused as to what happens, is you get fat cell infiltration effectively into the architecture of your liver. And your liver is like a complex, it's almost like a city block where you've got like organized traffic flowing in and out effectively. And then as things happen to your liver through metabolic insult, it's kind of like an earthquake hits it. And then they rebuild the roads in any which direction. And eventually you get congestion. And then eventually you get a failure of kind of metabolites flowing in and out of your liver in the simplest sense, right? And that can cause things like high blood pressure. It can cause congestion, a backing up of venous pressure into other parts of your body where it shouldn't be, and that causes all of the effects of liver failure, regardless of the cause. But the cause here is like really due to kind of fat infiltration into your liver. So to answer your question as to why this matters, it's because we're seeing in coverage, for example, like a lot of plans are excluding drugs for the purpose of weight loss. And they can get away with that to some extent. They can say like, hey, look, we don't cover weight loss drugs. This is cosmetic. But what we've seen is when someone has sleep apnea, for example, that you can appeal for a formulary exception on the basis of sleep apnea for the reason that it would be discriminatory to basically deny them on that basis if they have an AHI greater than, let's say, 15, apnea hypopnea index. And then with MASH, it's kind of the same. So you're then saying like, this is actually a recognized condition. This leads to severe consequences in like, honestly, like it's not decades, right? Which is like the thing with like a lot of diabetic complications and even weight related complications. The reason why the insurance industry takes this view of like, not my problem, is because it could be a couple of decades before hypertension becomes heart failure, becomes, whatever it becomes.
It's a much slower burn.
It's a much slower burn, and they don't care because it's not their problem. There's no collective action. But for things like MASH, like, yeah, actually in a Medicare population, that might happen under the same insurer. And even in a self-insured population for a long tenured employee at like a large company, that could happen too.
Yeah. So ultimately, so first of all, I'm sorry that you had to see your dad go that way. I lost my dad suddenly to a heart attack, and obviously there's these medications are being shown to be cardiac protective, and so it's hard in a way to see treatments come to market that could have changed the course. But I think especially for you and the way that you had to watch your dad go, like, I think one of the things that people don't understand about liver disease is a very ugly way to go.
Awful.
I can hardly think of worse ways to go than ultimately that end stage of liver disease. So MASH, if you can catch it early on, is very treatable. And essentially what you're saying is, even though this indication of obesity is a door that the insurance companies can slam shut because of the prescient nature of liver disease, it's not so easy for them to slam the door on accessibility.
Yeah, I think that's right. And there's a growing body of evidence, about treating this early versus like leaving it to become full-blown, liver dysfunction. And as there are different grades of liver failure, which are kind of in the Child's Pew grades, which, people can look up. But effectively, you want to stop people getting to the point where they have like any form of liver failure, and then it's reversible before that.
Yeah. So, okay. So two things. Obviously, Claimable exists to help people get access to these medications or to get access back to these medications when an insurance company denies that claim. For folks who maybe the idea of MASH is like new, what are some of the tests that they can go talk to their doctor about to make sure that their liver is in good health? Like, I think especially people with diabetes don't understand that these two things often go hand in hand, fatty liver and diabetes. Like, what should people be asking their doctor about, and then how can Claimable help them on the back end?
Yeah, so I think the things which are going to be required are one, blood tests. So you can get something called LFTs, liver function tests, that actually look at the synthetic function of your liver and making protein. And then the other thing is actually clearing bilirubin, which makes you jaundiced if your liver is dysfunctional. And then the transferase levels as well, AST and ALT, which show obstructive liver conditions, which steatohepatitis becomes, because it's really an inflammation of your liver for the reason of fat infiltration.
Is a standard a comprehensive metabolic panel going to include all this, or is this specific?
Yeah. So that would include it, and then the other piece is an ultrasound, liver ultrasound. So they can look for fat infiltration in your liver effectively that way.
Okay. So if somebody has been denied a access to a GLP-1, I mean, I know that oftentimes if you're diabetic, these things go hand in hand, but oftentimes if you're diabetic, you have pretty good coverage. Are you
Yeah.
seeing a lot of people with diabetes still having to fight prior authorizations to maintain access? And like, how are you guys helping them on the back end?
For diabetes, actually, the numbers have been pretty stunning. So I haven't looked at how many have come through lately on diabetes, but we were beating well over 80% of cases for diabetes. So it suggests that the majority of the volume has been for obesity, but for the people who come through with diabetes, yes, they are still seeing denials. Those denials are mostly bogus and they get overturned.
Mm-hmm.
They get overturned pretty easily with a well-reasoned appeal. On the obesity side, let me think about how to answer this. There are a couple of things. So when you back out to MASH, you can have MASH and not be diabetic. You could be pre-diabetic, which is also really interesting, right? So there's going to be this argument for coverage for patients who even aren't diabetic, but they might just be in the overweight, obese category, plus pre-diabetic, and now have another mechanism for qualifying. For obesity alone, I think the challenge that I've seen is one-plan exclusions for obesity alone are pretty hard to overturn. We've got a lot of warnings, kind of in the product, which is hey, you can try this. It may not be successful unless you have sleep apnea or MASH, for example, and then you need documentation of those things. That really boosts your chances of getting approved.
Okay. Well, I appreciate you coming on to talk about this a little bit today. If folks want to check out what you're doing at Claimable, what's the best way that they can do that?
Getclaimable.com. I think you can always tweet at me or whatever. I generally try to respond to people. People reach out through support. We often try and help them as well and help them reason their way through an appeal. We're really in it with you. The main thing, yes, we're a company, but the goal overall is to reset the coverage rules around these medications to actually make everything more accessible. Our belief is that if you can keep people healthier in the main, you will drive down healthcare costs longer term, if only people are able to take a longer term view. And then people can focus, more on their actual lives versus managing around the complexities of insurance denials and get back to feeling like a complete human versus a patient that's dependent on, an insurance company having mercy on them. So we want your voices to be heard. But,
Yeah, I appreciate that. And I know a lot of people who have used the OTP code, OTP10, save 10%. I mean, it's a very nominal fee when you consider the cost of these medications if you can get them covered. But I know many people from the OTP community have reached out and said, I was talking to Warris. I was like, oh, wow. Warris is pretty hands-on with all this. So if you have thought about checking out Claimable to get your insurance denial overturned, and you haven't pulled the trigger, I strongly recommend you use the tool. I know that you guys have started to have a lot more successes, and obviously you're learning as you go on how to be successful. You guys are part of putting together a lawsuit that is more coming. I love to hear it. Just really holding the feet to the fire on the PBMs on this stuff when they're illegally denying access to these medications. I appreciate the work that you're doing there, Warris, and appreciate you coming on and sharing today.
Of course. Can I add one more thing?
Please.
If you go to coveragefund.org for people at three times the federal poverty level can actually get access to GLP-1 appeals for diabetes through Coverage Fund.
Okay. So coveragefund.org. Do I have that right on the screen there? Mm-hmm. All right. So check out coveragefund.org. Warris, thanks for coming on and sharing a little bit today. Really appreciate you.
Of course. Talk to you.
Yep. Warris Bakari, founder of Claimable, a wonderful sponsor of the On the Pin podcast and doing amazing work to help you maintain access to your GLP-1 medication. If you haven't checked them out, please do. Lots of news this week in the world of GLP-1s, lots of things affecting accessibility, but we're in the fight with you here at On the Pin. If you found this video helpful, this information helpful, please consider subscribing to the YouTube channel and leaving a 5-star rating and review on the podcast. It really helps us grow. It really, folks, it makes all the difference in the world. Thank you for being here. Thank you for being the best part of what we do at On the Pen. As always, I couldn't, wouldn't, and shouldn't do it without each and every one of you. I hope you all have a great week, and I hope you'll tune in later this week for On the Pen Live. If you missed yesterday's interview that we did with Ethan Suplee, actor who has had a super successful career, but has been even more successful at taming the disease of obesity. Love my conversations that I have with him. If you missed that interview yesterday, please go back and check it out. Lots of good stuff coming from On the Pen this past week and in the future. So make sure you subscribe for all of it. And thank you for being here with us.